This meeting is being recorded.
Can start now.
Okay. So, good morning on this second Sunday. This is the third Sunday of the month. We could not do it on the second Sunday because of the annual conference at Kolkata, AICOG. So we have postponed this month program on next following Sunday. So today is the 15th January and we are having this PG tutorial from Fogsi Icog, and we acknowledge the coordination and cooperation of President Fogsi, Dr. Rishikesh Pai, and Chairman ICOG, Dr. Lakshmi Srikhande. She will be joining soon with us. And we have today in the program two cases. One is on female infertility from the students of Regional Institute of Medical Sciences, Ranchi. And we have Dr. Archana Kumari as the coordinating faculty. And students are Dr. Akanksha and Dr. Anjali Sinha. And we have another case, and we will try to discuss and cover male infertility also. The students, Dr. Nikita Reddy and Dr. Shweta, will present the case from Reproductive Medicine Department of Indira Gandhi Institute of Medical Sciences, Patna, and the coordinating faculty is Dr. Kalpana Singh. We have expert teachers to discuss the cases with the students is Dr. Ashish Kumar as usual, Dr. Sanjeeva Reddy from Chennai, Dr. Hemant Deshpande from Pune is not able to join today, Dr. Mala Srivastava from Delhi, and Dr. Kuldeep Jain from Delhi. He is again an IVF expert and a lot of work in male infertility. So that is why. So we thought that this month we try to discuss infertility, and in the exam we have all these cases. Mainly we have to focus on the workup of the cases and how to manage these cases. Now actually for the students in the MS and MD curriculum, a lot of things are included. Like we have to know about the ART also, we have to know about all the acts, whatever are happening in the country, and about the male infertility. The problem is we are not usually seeing the cases of male infertility, so our students are not exposed to this type of situation. So we thought this is the forum where we can discuss this problem of male infertility also, and at least the initial workup and initial few tips can be given to the students about the male infertility. So with this objective, this month PG program is planned, and I thank and I am very grateful to all my faculty, Dr. Sanjeeva Reddy, Dr. Mala Srivastava, and Dr. Kuldeep Jain, along with my team of Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, that you have spared your valuable time, and obviously, and we hope that you will give a lot of input to our students. I welcome Dr. Haresh Tosi sir also, who has joined, and I hope, sir, you will also take part in the discussion and give our students all the comments and the tips for their exam and for their guidance as a future obstetrician and gynecologist also. So purpose is this, and thank you for joining all of us. And I can tell you in the beginning only that the recordings of all these programs are also available on the ICOG websites, and ICOG has taken this initiative for this program on every second Sunday of the month in the morning from 11:30 to 2 p.m. on every month. So with these words, I just first of all invite Dr. Ashish Mukhopadhyay sir to say a few words, and then we'll start the case presentation.
Yes, good morning everyone, and welcome to the PG tutorial. And as you know, as Dr. Ashok Kumar has said, that we actually hold this program every second Sunday of every month. Because of the AICOG, we had to postpone it a bit. That is the following Sunday we are taking this. But next month onwards, it will be once again second Sunday. And as he correctly said, we have taken up infertility as a theme subject this month, and the two institutes are there. So I would like to call upon the first presentation I believe it is from RIMS, Ranchi, the students to present the case.
Okay, sir.
Also, I can see that I think Akanksha and Anjali, are you joined in with two devices? Then sign out from one device, and because this will create problem.
Okay, sir. Okay.
Thank you. So could we start the first case now?
Yes.
So start sharing your screen and start your presentation. Any problem?
No, sir.
Start.
Good morning to all faculty members, my colleagues and online viewers. We are going to present a case of female infertility. We are Dr. Akanksha and Anjali from RIMS Ranchi, and our coordinator is Dr. Archana. Patient detail. Neha Kumari, 30 years old.
Share your screen.
So your screen is not visible.
Are they made co-hosts?
Yes, yes, sir. They are co-host.
Okay.
Yes, yes.
Yeah.
Now it
Yes,
is
now
visible.
visible.
Put it on the slideshow.
Full screen, yes.
So it's visible now, no?
No, it is on,
Yeah,
not
but
on the
put it on
slideshow.
Slideshow.
Ma'am, please put it on slideshow.
Click
Upper
it
side.
here. Click on this.
Next. Animation, near animation.
Yes, slideshow में जाओ ऊपर.
यहाँ पे, यहाँ पे. Go to the slideshow.
Yes, that one. From the beginning.
Yes.
And meanwhile, I take this opportunity to welcome Dr. Padamja from Vijayawada also. She is also here. I request her also to take part in the discussion, Dr. Padamja.
Yes, Dr. Ashok.
Yes, welcome to this program.
Click it on the from the beginning. Click that icon and it will come.
Komalji, if you can put it on slideshow, is it possible?
No,
So we-
sir. Actually, they only have to do it from beginning. Yes, click that one.
So we are paid from the beginning.
If that's not happening, go to the bottom. There is notes, comments, and you can see the icon there, single 4. So move down.
उस icon पे करो.
This
click
one.
that. Click that.
Oh, it is not happening, so you present
No,
like
so
that.
go
No
ahead.
problem. No
Go
problem. Just go ahead.
You can do one thing, that you can close it and once again you can open it and then you can put it on slideshow.
Not happening.
Akanksha, you send that presentation in the WhatsApp group, then I think somebody else can share.
Okay, ma'am.
And meanwhile, you just keep on trying. Try. This is not happening. What has happened here?
So it is being viewed from second slide.
If it is visible, you can continue like this only. There is no problem.
Yeah, from any slide you
Please
can
continue.
So
If it
from
is visible
our
on
side,
this, Komalji, is it visible on this?
No,
Then-
sir, it is not visible.
share kar di sir ko.
Akanksha, stop the slides sharing once. And then again share because we are not able to see. Yes. Now try.
Yes, it has come.
Mm.
Yes. Now just see if it goes to slideshow or otherwise you continue like this. Yes,
Yeah,
it is there now.
Now it is visible.
Yes. Now you continue.
That's
Good
the
morning
hide
to all.
button now. Hide.
Yes, continue.
Good morning to all faculty members, colleagues, and my online viewers. We are going to present a case of female infertility, Dr. Akansha and Anjali from RIMS Ranchi. My patient Neha Kumari, age 30 years, graduated, housewife, belonging to lower middle socioeconomic strata, resident of Baryatu, Ranchi, came to our OPD with complaint of failure to have a baby since past 3 years. The female partner also had complaint of fever and malaise since 6 months. Couple presented to RIMS OPD with complaint of inability to conceive in spite of regular unprotected intercourse since 3 years of marriage. No history of previous evaluation and treatment were taken by the couple. She also gives history of low-grade fever on and off since 5 months. Fever was intermittent, associated with malaise, decreased appetite, and lassitude, for which she took paracetamol tablets. No, there was no history of menstrual irregularities, history of acne, excessive facial hair, and weight gain. No history of abnormal vaginal discharge or itching, of burning micturition, low abdominal pain, or backache. There was no history of dysmenorrhea or dyspareunia. There was no history of postcoital or intermenstrual bleeding. There was no history of mass per abdomen or cold intolerance or constipation. There was no history of decreased libido or no history of nipple discharge or galactorrhea. Menstrual history. The female attained her menarche at 14 years of age. Her LMP was of 2nd September 2022. Her cycles were regular, which occurred at an interval of 28 to 30 days. The amount of flow was average, for which she used to take 1 to 2 pads per day, and there was no history of dysmenorrhea or passage of clot by the female. Obstetrical history. She was nulli gravida with non-consanguineous marriage and married since last 3 years. Past medical and surgical history. There was history of on and off low-grade fever for which she self-medicated herself with paracetamol tablets and never sought medical help for the same. There was no history of endocrinopathies like thyroid disease, diabetes, tuberculosis, PCOD, pelvic infection, or endometriosis. There was no history of any surgery, including gynecological or pelvic surgery. Family history. There is history of tuberculosis in the family. Mother-in-law took ATT for 6 months for 1 year back for pulmonary coughs. There is no history of early menopause or treatment of infertility in the family. There is no history of diabetes, thyroid disorder, or hypertension. Personal history. She has normal bowel and bladder habit, adequate sleep-wake cycle. Patient is non-alcoholic, non-smoker, not addicted to any drug or substance, and there is no known allergy to any drug or substance. Nutritional history. Patient has decreased appetite since past 6 months. She takes mixed diet. She takes 2 to 3 major meals per day. Her diet contains more of carbohydrate, less of protein, vitamins, and mineral. Her average intake was of about 1800 kilocalories per day. Socioeconomic strata. She belonged by modified Kupuswami scale. She belonged to upper middle socioeconomic strata. The head of the family was the patient's husband.
Good morning, everyone. Myself, Anjali Sinha. I will be proceeding this presentation from here. Now, the partner history. His name was Ram Kumar, 36 years of age. He was a graduate and a shopkeeper by occupation. He was well-built with a normal BMI of 24 kg per meter square. He was an occasional smoker with no history of alcohol or drug abuse, no history of decreased libido, No history of polyuria, polydipsia. There was no complaint of erectile or ejaculatory dysfunction. No history of undescended testes, mumps in childhood, or no history of testicular trauma or enlargement. No significant medical or surgical history, including the testicular or genital surgical in past. Now the sexual history, the couple was in healthy heterosexual relationship. The couple is aware of the fertile window. The intercourse was 4 to 5 times a week without the use of contraception. No history of use of coital lubricants or dyspareunia. Now in general examination, the female partner, patient was conscious, cooperative, and well oriented to time, place, and persons. He was thin built with a weight of 45 kg and a height of 152 meter, which accounts for BMI of 19.48 kg per meter square. Her waist circumference 128 centimeter. The pulse rate 86 beats per minute, which was regular in rhythm, fair in volume. BP 120/80 mmHg in sitting position in left arm, and a respiratory rate of 12 per minute. With a mild pallor, no icterus, edema, cyanosis, or clubbing seen, no lymphadenopathy was found, and no thyroid or neck swelling was seen. On systemic examination, cardiovascular system, normal S1, S2 was heard, no added sound was present. On respiratory system, chests were bilaterally clear, and CNS examination, there was not any abnormal detection. On abdominal examination, on inspection, no scar was present. Umbilicus was center and everted. All the quadrants are moving equally with respiration. No lump or mass seen. On palpation, on superficial palpation, temperature was normal. No superficial tenderness was present. On deep palpation, no lump or mass was felt. On no organomegaly was found, including the hepatomegaly or splenomegaly. Now the local examination, on inspection, the pubic hair distribution was normal with normal vagina and vulva. On per speculum examination, cervix appears to be normal, mucoid discharge present in the posterior fornix, which was odorless. On bimanual pelvic examination, uterus was normal size, anteverted, mobility was slightly restricted, pelvic tenderness was present, and bilateral adnexa was free. Now the summary of our case, a nully gravid female of 30 years of age whose husband was 36 years. They belong to a middle socioeconomic strata, presented with a complaint of failure to conceive since 3 years of married life. Female partner had a history of fever associated with malaise and decrease of appetite since last 6 months. Her menstrual cycle were normal. No surgical intervention was done in the past. She had a family history of tuberculosis in first degree relative, and her personal history was unremarkable. Her husband was occasional smoker. They had a regular unprotected intercourse since 3 years of married life. They were aware of the fertile window period. On examination, general condition was fair. Patient was of thin build, mild pallor. Systemic examination was unremarkable. On per speculum examination, mucoid discharge was present. On bimanual examination, uterus was anteverted, normal size, form, and mobility was slightly restricted with a mild tenderness present, and the bilateral adnexa was free. Now my provisional diagnosis is a case of primary subfertility with a pelvic inflammatory disease.
Okay. So, Dr. Reddy, you start this thing, crossing at this point. Please unmute yourself, Dr. Reddy. Dr. Reddy, please unmute yourself. You are muted. Yes.
Okay. Ashish, you can take the history of this patient. You can have discussion. We will involve in infertility.
Yeah.
So please pardon.
Is it audible?
Yeah, you're audible. A bit louder,
Hello?
please.
Yes,
Dr.
sir, you're audible.
Okay. Your diagnosis you told is pelvic inflammatory disease, no?
Yes, sir.
Yes, sir.
What are the points in favor of why you are thinking it is a case of pelvic inflammatory disease?
So because she, on post speculum examination, we got cervical mucoid discharge, and on bimanual pelvic examination, there was mild tenderness. Mild fornical tenderness was present and mobility was slightly restricted.
This is Akanksha, I believe. Akanksha,
Yes.
whenever
Yes,
you
sir.
are asked such questions from the examiner, always start with the history. What are the pertinent points in the history? You don't go to the cervical discharge and bilateral motion tenderness, etc. straight away. Pelvis is not the only area of examination. You have to
Yes, sir.
explore what are the points in favor of pelvic inflammatory disease in your own presentation. Okay. So
Yes,
what are
sir.
the points in the history which is suggestive of pelvic inflammatory disease to you?
Sir, in the history,
So first of all, the patient came with a complaint of infertility and history of fever from last 6 months. And second, she gave a menstrual history which was regular. The cycles were regular, and the fever was associated with malaise and loss of appetite. And she also had a family history of tuberculosis in her first degree relative. And
So there are so many factors that help in the provisional diagnosis. There are a lot of
Yes.
contributory factors also, like socioeconomic status, like the
We
kind of
also know
nutrition you have
socioeconomic status.
mentioned. Yes, there is some amount of nutrient deficiency in the diet, and also she has these symptoms, and also a strong family history of tuberculosis. You must start with all these things. Then you
Yes,
go
sir.
to the abdominal examination. Then you go to the local examination, because this is a clinical diagnosis. You need to explore all the points that are available from the history and from the examination. Okay, always start with history. Any
Okay,
question in the long case, regarding management, regarding investigation, you should always start with the history. If you don't do that, examiner will have a poor idea about your history taking. Okay.
Okay, sir.
Okay, sir.
Yes, Dr. Reddy, anything you want to say, sir?
So here, what I can see is she's very fond of no, 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 no. Everywhere it is only no is there. Why it is so many no's, I don't know. Like, any important points are there that you can tell like that? Why everywhere no like that? Do you expect every patient will be having no cysticism or no all these things? Why so many no's? No, if there is there, if it is not there, or significant things you can find out. No need for us. For MBBS students is okay. For PG students, not advisable these things. And what you are telling, because she is feeling like I'm thinking because of anemia, we're telling the patient is anemic. That's why she may be malaise, may be there, other things. Because of that one, you cannot say this is tuberculosis or something else. She is not giving any history related to pelvic inflammatory disease. Just because there is some discharge, you take 90% of patients will be having some discharge in the vagina if you examine. And if you, depending upon how you are examining, every patient will feel pain. Because of that one itself, you cannot say it's a pelvic inflammatory disease. Okay.
Yes,
You are
sir.
thinking it is pelvic related to infertility. Suppose that is her problem. Like if you are thinking it is tuberculosis or something else, she might have gone to the physician or pulmonologist long back. You are telling there is 6 months history there. No, she has come to you. She wants to become pregnant. That means that other problem is very negligible. That's why she has come to you.
Yes, sir.
Okay, you are suspecting or pelvic inflammatory disease. What you are going to do next? You tell me. Hello?
Sir, your voice is not clear with us.
Hello?
He's
Audible?
asking what you will do next.
Treatment, management. So we'll first investigate the patient.
Okay. What investigation you would like to do now?
So we'll first we'll first investigate the male partner. For male partner, we send the semen analysis, blood sugar, and
You are telling
serology.
what has come to you. You are going to investigate the male partner. Okay, male partner, what investigations you want to do?
So
Semen
analysis, blood sugar, serology, HIV, HBsAg, VDRL. In female partner, we'll do the routine CBC, blood sugar,
and the hormonal profile, LH and FSH.
PID के लिए पूछ रहे हैं ना? serology, pap smear, routine and urine and culture sensitivity. And as she
Okay, yes, we have come to you.
And as she has come
Female
with
partner has come
infertility,
to
ma'am,
you. So
we'll
no doubt.
do the hormonal profile, for which we'll send LH, FSH, prolactin, anti-Mullerian hormone, thyroid profile. We'll do a baseline ultrasonography to rule out pelvic pathology. We can do HSG, sir.
No need for us to go and do the hormones for all infertile patients. Just like that, she has come, you are thinking there may be inflammatory disease. What you have to do next? So you are in the outpatient department. She has come to you. Will you write and give all the investigations? Yes.
No.
You have to first diagnose what is
Yes.
the problem. Then only depending on that investigations we can do. No need for us to go and do FSHL, all these things for her.
Okay,
sir.
Dr. Kalpana Singh wanted to say something. Yes, Dr. Singh, please unmute yourself.
Madam, unmute Kalpana.
For allowing me to speak, because I was there, but I was not able to speak anything. Thank you, sir. So I just actually I was not co-host, so I was not just able to participate in the communication and talk system.
Okay. See here, this patient has come. Thinking it may be pelvic inflammatory disease. That's okay. It is not suggestive. By history is not suggesting. Clinical examination also is not suggesting, but you are suspecting. That is okay. So next, no need for us to go for any hormonal thing. If there is some problem related to that, then only you are going for the hormone. Here first you have to do the transvaginal scan. You are thinking there may be inflammatory disease, other things. Okay, you have done. Have you done any transvaginal ultrasound for this particular patient?
Yes, sir.
Hello? Hello?
Yes, sir, we did transvaginal sonography.
Have you done this scan for this patient?
Yes,
Yes,
sir.
sir.
Can you tell the findings?
So the findings were normal.
Okay, then what you will do? So you advise the husband semen analysis. We hope that semen analysis also is normal.
Yes,
Here,
Yes, sir.
menstrual history is normal. You are suspecting
With tubal
pelvic
fracture.
inflammatory disease, and there is strong history of tuberculosis there in the family. What you want to do next? Okay,
So,
just
so we want to exclude any findings related to tuberculosis in our patients. Therefore, we send the investigations on the line of tuberculosis as well. We did chest X-ray, PA view, Montauk's, endometrial biopsy, CB nat of menstrual blood, TB gold, TB quantiferon gamma assay, HSG. We didn't did HSG, sir, here because we wanted to confirm whether she was actually having a TB or
Active
not.
TB or not.
okay.
And
Chest X-ray is showing any abnormality?
no, sir, there was no abnormality in the chest X-ray.
Okay.
All the
How the
investigation
Montauk
regarding
test
the
is going to help you?
So Montauk's test was positive, and the CB nat of menstrual blood which we sent, that was also positive.
For this patient.
Yes,
Yes,
for
sir.
this patient it was positive. Therefore, we didn't did HSG. We went for laparoscopic chromoperturbation.
Okay. What is the findings?
So on laparoscopic chromoperturbation, there was beaded appearance on left side of the fallopian tube, and there was decreased
delayed
flow of dye on the left side, and
after
there was,
multiple injection
and on right side the tubes were normal
and the patent also.
and patent.
Suppose endometrial biopsy you want to take in a case of suspected tuberculosis patient. When you will advise, take the biopsy.
So on 21st to 24th day of the cycle, or immediately as the menstruation sets in.
Biopsy was taken for this patient.
No,
No,
no, sir, biopsy was not taken.
Okay. The laparoscopic tubes were patent.
So, sir, on
Right
right
side,
side, the tube was patent,
patent.
but on left side, there was diminished flow.
After multiple.
Left side. Can I repeat?
Left side, there was diminished flow
Delayed.
or delayed
Okay.
flow of the dye, and there was beaded appearance on left side.
Okay. Suppose you had taken the biopsy, it came as a negative.
Okay, sir.
Anti-tuberculosis treatment. What drugs you will give?
So we'll start the patient on tuberculosis for ATT, which is a 6 months regimen, which combines 2 months of HRZE and 4 months of HRE.
Okay. So this is just we'll wait for some time. Tuberculosis is not there in this patient. How will you proceed next? Suppose there is no history of fever is there. This patient has come to you, except only that she is anxious to become pregnant, married for 3 years. There is no that she is getting regular period. Why you have written that in September sometime only LNP?
So, your voice.
LNP is September you have put, no?
Yes,
She's
sir.
getting regular periods.
So we examined the
You
patient
think
in
that-
September. We have taken the history in September, sir.
Okay. Suppose he is
The
getting
patient
regular
was of
period.
September.
LNP, he has come to you. You are doing ultrasound scan, transvaginal scan. Just tell me what are the things you will see, you want to know in the pelvis, uterus, endometrium, tubes, ovary. What are things you will concentrate in an infertile patient? So in gynecology, we are happy to see the uterine size, whether ovary size, when follicle is there or not that much, or anything abnormality is there in the tubes. Here, particularly in infertility, what are the things you want to see? Anything different in infertility will concentrate?
So when we'll do transvaginal sonography, we'll first look over the
Merely on the tubal factor, whether hydrosalpinx were present or not, or there is any collection in POD or not.
In the uterine cavity, we'll see whether if there is any fibroid or any space occupation
or polyp.
Or there is any polyp.
Normally, you cannot visualize in a normal patient unless there is a hydrosalpinx is there. I am not bothered about that one at all. Uterus, you can visualize. No, in that any abnormality you will make out. You will be interested. Fibroid, it won't be there in the cavity. That is very rare. So where else you will get the fibroid? Commonly.
Where will the fibroid?
So just repeat.
Okay, one day we are going to see whether there is fibroid is there or not. Anything else? See, remember like this. See, uterus and ovary, 2 things important. Third one is the tube. Uterus also serosa, myometrium, endometrium will be there. In that
myometrium and endometrium.
What are the things you will try to say? Check.
Sir, we'll check over the endometrial thickness.
Okay, good.
Whether it is trilaminar.
That depends upon which period of the cycle you are seeing. Then only you can get the trilaminar. Suppose it's third day you won't get. Okay, one is you want to see the endometrial pattern and thickness. Okay, anything else? The cavity?
Sir, any endometrial polyp?
Adenomyosis or polyp.
Or you can say that submucous fibroid also. In the myometry, what are things you will check?
Adenomyosis.
Yes, good. One is fibroid, second is the adenomyosis. These things you have to concentrate. Tell me how you will diagnose the adenomyosis by ultrasound? How the picture looks?
Hyperechoic lesions in
shade of hyperechoic lesions are seen.
No, we have to many times we will get confused with the fibroid, no? Adenomyosis
Yes, sir.
and fibroid. We have
Sir, in fibroid, it is homogeneous,
should
whereas
know
in
the difference.
adenomyosis,
We
these
have
are
to differentiate.
heterogeneous lesions which are invading the myometrium.
Invading the myometrium. Hmm.
There will be asymmetric
Suppose
thickening
we
of the
have a
myometrium.
Doppler thing. Is there any help? The myometrium will be there in the fibroid also. Like suppose if the anterior wall will be there, that will be thicker, and posterior wall will be thin. That is different. That's the one way. Any other
Yes, sir.
thing? Will Doppler will help us?
Yes, sir.
How? How the blood flow will be there in the fibroid and adenomyosis?
Sir, in fibroid, the blood flow will be from periphery to the center, whereas in adenomyosis, it will be central.
Okay, it will be in the capsule only, round like that. No, inside it
Yes,
won't, you
yes,
won't
sir.
get. You cannot see.
Yes.
So in adenomyosis, everywhere the blood flow will be there. That way, and cavitations will be there in the adenomyosis. That way also you can make out. Unless if it is localized in adenomyosis, adenomyoma like that, there you can get confused with fibroid. Otherwise, depending upon the type of fibroid, you will have most of the time hypoechoic. Yeah. Okay. Next in the ovary, what you will see?
So in ovary, we will see the number of follicles, size of ovary, any cyst or present or not.
Number of follicles and size.
In the volume of ovary.
Okay, one is volume. Anything else?
So number of follicles.
Number of
What type of
Number of
follicles?
follicles, the size of follicles.
No, what type of follicles you will be interested? Third day, what type of follicle you will get?
Small follicles. Small follicles.
What is
Antral.
that called? Oh, tell.
Antral follicle.
Antral follicle count. Good.
Yes, sir.
What is the size usually we will call that one? So when we are measuring from how many millimeters to how many maximum millimeters, we will call it as antral follicle. Okay, 2 to 9 millimeters will take. Is it necessary
So
to
if the
measure
antral
the
follicle count is less, hello. So if the antral follicular count is less than 4, then we take at a thing that the ovarian insufficiency or less ovarian reserve.
Okay, tell. So it is important for us, even if you're not doing blood tests, other things, to know how many antral follicles are there. You're telling me whether it is less, normal, or more.
Yes,
So,
less
like,
than 4 is poor response from the ovarian reserve. Or 10 or more than 10 is normal with a size of 2 to 10 mm.
okay. So yes, the antral follicle count also is normal. So you have done the thing. Suppose then in this, you'll forget about this tuberculosis, this one. There is no history of fever or other things. Suppose in this patient you have done the scan, the uterus is normal, ovary size also is normal, antral follicle count is also is normal. Then how will you proceed next?
If we will rule out the ovarian factor, then we will go to tubal factor and we will go for an
Okay,
HSG.
male factor, you advise seminal is normal in this patient. Husband normal.
Yes, husband was normal.
Female
Yes,
factor,
husband.
patient came, you did the ultrasound transvaginal scan, it is normal. Next, what?
Okay.
How?
So we'll rule
Next,
out the
how will you
tubal
proceed?
factor.
So we will
Yes,
go for
good.
HSG.
Okay. HSG, you told no, right side tube is patent, left side there is a block is there. How
Yes,
will
sir.
you do? What you will do next?
So we will, if any abnormality is detected on HSG, we go for laparoscopy.
See, one side is patent. Only left side is block. Right side is patent. We'll go for laparoscopy.
If it's proximal block, then we will not go for laparoscopic because the proximal block may be present due to spasm.
Okay. No. See,
Is it
one
okay?
side is tube is open. Left side alone is block.
Yes, sir.
To do anything here, you can treat this one as like both tubes are open. Okay. Suppose
Okay.
the patient.
So your voice is
So
not.
male factor is normal. Here, hello.
Yes, sir.
Is it audible now?
Yes, sir.
The male factor seminal is normal. Tubes patent. So what you will do for this patient now?
So since the tuberculosis tests were positive, we'll start the patient.
Don't bother about tuberculosis. Forget for some
No,
time. Don't think about this patient.
Okay.
Here,
Okay.
a patient has come to you. She is married for 3 years. Is normal. Male factor seminal is normal. You have done the HSV. HSV also both tubes are patent. What you are going to do? Presume this one is unexplained
If we will rule
infertility.
out the male factor, the ovarian factor, and the tubal factor, now we will go for the uterine factor and detect any uterine abnormality is there or not. If we have done the USG, there is no fibroid, no adenomasis, then we can go for hysteroscopy to see any adhesion.
For hysteroscopy. Is it audible or not, my voice?
Yes, sir. It's audible, sir.
Okay, just see, you have done the ultrasound scan, there is no abnormality. So then you went and did the HSV, both. Also within normal levels. Then how will you proceed here? I'm telling you, it may be unexplained infertility. Tubes are normal, she is ovulating. Every month she is getting periods. Male factor also is normal. How will you proceed next?
Dr.
So
Sanjeev,
we'll start the patient for ovulation induction.
Dr.
Okay.
Reddy, your voice is breaking. I think that there is some network issues there. They cannot hear you properly, maybe. Okay. So I think that what Dr. Reddy was talking about, another case, not this case. Now let us come back to this case. You said that you are diagnosing a case of ovarian insufficiency, or rather poor ovarian response.
Ovarian insufficiency. Now it is everything is normal, unexplained infertility.
Yeah,
is it audible now?
It is
Yes,
audible.
sir.
Okay. It
It
is
is on.
ovulation induction you are telling, no?
Yeah, we will do ovulation induction with IUI.
Very good. What drugs you will give? What drug you will give for the ovulation induction?
So clomiphene citrate or letrozole.
For if it is case of PCOS, then we will go for the drug of choice is letrozole, or otherwise it is clomiphene citrate.
How much you will give?
For letrozole, its dose is 2.5 milligram. We start on day 2 or day 5, and it's OD for 5 days. And for clomiphene citrate, it's 50 milligram. We start from day 2 or day 5 and OD for 5 days.
Is it necessary to monitor the cycle?
Yes, sir.
Yes, sir.
To see the response of whether the patient is responding
to the drug
to
or
see the
not.
size of the follicles.
When you will ask the patient to come?
We will ask the patient to come after the completion of the drug, that is on the day 11, and we will do a TVS to see the size of the follicle. And if the size of the follicle is, if any one follicle size is more than 18 mm, then we will give a trigger.
What trigger you will give?
Sir, HCG, injection HCG 5,000 international
IM, the single dose.
Okay, then what you will do?
Then after 48 hours, sir,
We will ask the patient to do a timed intercourse after 36 to 48 hours. It's compulsory intercourse.
No, you said you will do the IUI, no?
So?
You said you will do the IUI. This is ovulation induction and IUI, you told.
Okay.
Today you have given the trigger. You will ask her to come after 48 hours.
After 36, yes, sir.
Okay, 36 hours.
Yes, sir.
Okay, you have done the IUI.
So then we'll do an ultrasonography to see whether the follicle size is
whether the
whether follicle
fertilization
dissection, it has ruptured or not.
Okay, ruptured, you have done the IUI. What precautions you will take then? Will you advise, what advice you will give? Hello?
Yes,
so
sir.
we will do an regular USG to see whether the implantation has occurred or not, or we will
Any
tell
luteal
the
support is needed?
Yes, sir. We'll give
Yes, sir,
luteal
luteal
force
force
support.
Okay. So how many cycles usually you will advise IUI? Suppose you
6.
didn't conceive in the first cycle, how many cycles you can advise?
so at least for 3 cycles.
Okay, 3 to 4. If it is not
3 to 4.
there, more than that, you have to go for the IVF. That's something. Why these 3 cycles? Any reason is there?
So while induction, it may be that the ovulation has not occurred, the patient is not responding to, not
See,
compliant to the drugs. So to just see to at which dose the patient is compliant, we will at least do the ovulation induction for 3 cycles or maximum to 6 cycles.
see, you listen to the person, please. You are doing
Yes, sir.
IUI. Everything is all right. Follicle is growing. You are given the trigger. You have done the IUI. So she
Yes,
is
sir.
not conceiving. You told like that you will do 3 times IUI. Is there any reason why it is 3, why it is not 6, why it is not 10?
Sorry, sir.
No. Any reason is there 3 cycles only IUI you are doing? Is it audible or not?
Yes, sir. It is audible, sir.
Okay, usually after 3 cycles, the cycle fecundity will come down. Usually the pregnancy rate will be 8 to 12% only for IUI if you do once. So it will drop down to 3 to 4%. No point in after four cycles if you do. After 3, it will come down. That's why it's not advisable. Go for the IVF. Okay. In this case, you have done the HSC. It is showing bilateral cornual block. What you will do next?
So we will go for laparoscopy.
Okay. Why you want to go for laparoscopy? Why not IVF?
So
Sir,
because
because
cornual block could be
physiological.
Okay, that is false positive is there, no?
Yes, sir.
What is the chance of false positive in a case of HSG showing bilateral cornual block?
45 to 50%.
It will be around 35% they will be having. So because of spasm, or sometimes there may be some mucus plug also may be blocking. That's why you have to go for. Suppose you have done the laparoscopy, hysterolap. We won't be doing laparoscopy alone, both combined. You have done, tubes are externally normal, ovary is normal, there is no endometrial spot, anything. So you injected the dye, there is no spill. What you will do?
So if there is no spill, then we will see the which segment of the tube is blocked.
I told you this is cornual block. No, we have seen.
Yes,
Now
it was cornual block.
Then we will go for tubal canalization.
Yes, very good. If it is a proximal thing, there is no peritubal additions. Externally, everything is normal. So you can go for the proximal tubal cannulation. That's why when you are taking a consent with the patient, always when you are going for this type of hysterolaparoscopy, take consent for proximal tubal cannulation also. You can try that there. Almost 60 to 70% of time you will be successful and the pregnancy rate also will be good. Suppose the HSG is showing mid-tubal block. How will you manage this patient?
So mid-tubal block is mainly seen in
sterilization
surgery. Previously, any tubal surgery has been done.
No tubal surgery. The same your patient only. First finding was cornual block that you told we are going to do the laparoscopy. If there is tubes are normal, you are going to go for the proximal tubal cannulation. Here, the HSG is entering 2 to 3 centimeters. After that, there is no dye is going. In the tube for first 2 to 3 centimeters, you can visualize. So
Okay,
you
sir.
subjected this patient also for laparoscopy, histrolab. Here also tubes, everything is normal, but dye is not coming out. What you will do for this patient?
So we will go for anastomosis, isthmic anastomosis.
See, most
For
of the
mid-tubal
time, if the mid-tubal block is there, it is not successful unless as you are telling, no, she might have had tubal
surgeries,
previously,
sterilization surgeries.
then you can go for the anastomosis. Otherwise, mid-tubal block means you have to go for the, most of the time, go for the IVF. Suppose here, there is distal tubal block is there. HSG is showing distal tubal block. How will you manage?
Sir, distal tubal block is mainly of three types:
types.
mild, moderate, or severe. In mild cases, there is only a agglutination of the fimbria. Then we will go for fimbriolysis. And in moderate case, there is a phimosis of the fimbria. Then we will go for fimbrioplasty. And in the severe cases, we have to form the new salpingostomy.
Okay, that's the one option is there. What precaution she has to take? What advice you will give to the patient? You have done the successful surgery, so neosalpingostomy or fimbriolysis, what you have done. So what advice you will give? What precaution she has to take?
Sir, there is a high chance of ectopic pregnancy.
Very good. So that is the problem. You have to tell them any surgery on the tube, the chance of her ectopic pregnancy is very high. Whenever she misses her period, she should come and consult to the nearby, like tertiary care centers. She has to go there. We have to exclude whether the patient is having ectopic or not. That's the one thing. Okay,
Yes,
just going back, you are telling a PCOS, no? You said you will give the letrozole.
Yes, sir.
Dr. Reddy, I think we are running out of time. So I will rather suggest that you come back to the present case. They have some issues about, they were talking about this tuberculosis.
Okay.
Whether they will go for the confirmation of diagnosis. I think they have fairly confirmed the diagnosis. Now there is a question of whether they should go for medical management first, followed by the treatment of infertility. You ask them that.
Okay.
Because the time is going to run out. No, in another 10 minutes, we have to wind up and give to the second case.
Okay. You tell like that your case, you told that CB90 is positive, other thing. So you confirm this is a case of tuberculosis. So how you told like that you are going to give the ATT for 6 months.
Yes, sir.
Yes, sir.
Okay, 6 months, no treatment is over.
Okay,
So
sir.
then now itself you have done the laparoscopy for this patient, no? You told right
Yes,
side
sir.
tube is patent, left side there is slow spill is present.
Yes,
Yes,
sir.
sir.
How will you confirm whether your treatment is successful or not? 6 months is over now. How will you know whether the patient is completely cured or not?
So we will do the HSG.
HSG they will do.
HSG will you do? HSG is going to show whether this block is there or not. Anything else you will do? How will you confirm whether there is a genital tuberculosis cured or not?
We'll repeat the CB9.
We'll repeat CB-NAT.
Can you take the endometrial biopsy, repeat endometrial biopsy?
Yes, sir.
Yes, I will take the
will
endometrial biopsy.
Okay, you have confirmed here. Okay,
While
that
taking
is
the
also
endometrial biopsy, I must remind you that endometrial involvement in tuberculosis is almost 50%, whereas
Yes.
fallopian involvement is almost 100%. Okay.
Yes, sir.
So I think that, yes, you can go for the endometrial biopsy. Well, like you haven't taken the endometrial biopsy till now. So endometrial biopsy you may take. But the main question Dr. Reddy was asking, whether after 6 months of therapy, how do you know that the treatment is completed or you need more medical treatment? Or you go for the ovulation induction and all those sequence of events that you have already said. That is what he wants to know.
So her symptoms will be fever.
Symptoms are
So
hardly.
since the patient showed signs of clinical improvement on the basis of her appetite, the appetite improved. The lassitude was also decreased. Her appetite improved. Weight also improved. Her weight, she gained weight.
Okay,
There is
after 6 months, these changes are quite possible to point towards the improvement in that. But there are more specific features which will point out to the success or partial success of the treatment, isn't it? Because fertility interventions are quite sensitive issues, and the patient is highly willing to try for a baby. So you have to give them definite indication that yes, this is the point where we should go for the all-out treatment of infertility. Okay, so when do you declare that the patient is cured? How do you know that?
Okay, you have done the endometrial biopsy that has come as a negative. Then you have
Yes,
done the HSG, same findings, right tube is patent, left side also is, there is block or something is there, or slow spill is there, little you can see. So what else you will do when you are doing scan in this patient? One is you want to exclude tubal factor here. Next is anything else you want to check post tuberculosis?
either there is any uterine adhesions or synetia formation.
Okay, what you will do for that? You have done the HSG, there we are not
Yes,
seeing
sir.
any intrauterine adhesions.
Yes, sir.
So HSG, you can see the intrauterine adhesions. Here it is not seen. That is also
Yes.
one thing we have to always, if there is suspicion there, you can go for the hysteroscopy and exclude that one. Okay, one more thing is important here. Tubes, we want to see whether there is block is there or not. And anything else, endometrium also is important. Tuberculous endometritis, one problem will be thin endometrium. That is the
Thin
problem
endometrium.
here we'll be getting. Okay, here the endometrium is normal. What you will do? Tubes are
We'll go for
patent.
ovulation induction.
Okay, go. Suppose the tubes are blocked, what you will do?
So we'll go for tubal surgery.
No, tubal
I think
surgery
we have
won't be
discussed this before.
successful.
Dr. Reddy, we have discussed about this thing, tubal
No. Here
blockage.
in this thing, so here tubal factor is there, it's not successful. They're telling they will go for surgery. Tuberculous thing, you won't be successful, not advisable.
Yes.
Suppose the endometrium is thin, what you have to do now?
So if the endometrium is thin, then the uterus is not, we cannot go for IVF in that patient, then we can go for surrogacy.
No, not all patients. You can go for IVF also. There is chance is there. Persistently thin endometrium, she is not conceiving with after transfer also, then we can go for the surrogacy. Just tell me like that, you are telling you will go for IVF. Indications to go for IVF, you just tell me. Dr. Ashish is telling time is over like that, we have to finish. Tell me indications for IVF.
You have to finish
Which are
it
the
before this
conditions
time.
to go for
Indications
IVF?
are, so we will take in consideration the age of the patient. If it's more than 35 and there is any other component which is abnormal, that is there's a tubal block or there is not responding to any ovulation induction, then we will go for IVF. Or there's any severe male abnormality in semen analysis or azoospermia, then we will go for IVF.
There is no azoospermia, sperm counts are normal. Is there any male factor where you can go for?
Oligospermia. It's a sperm impotency.
There you can go for IUI,
Okay, sir.
If
You will collect and give the semen, we can do the IUI,
if the husband has any genetic disease.
Yes, that is also one thing is there. There, if you are going for the PGT, PGS, so there also we can go for these things. Okay. Okay. Anything else, Ashish?
Yes, actually, I wanted to conclude this discussion with the following remarks that we haven't discussed about few investigations like sonosalpingography. Are you doing this in your institutions? Sonosalpingography, are you doing
No,
it?
sir.
You're not doing it. Okay, so you have to depend largely on hysterosalpingography and the laparoscopy, isn't it? And
Yes,
of
sir.
course, laparoscopy with hysteroscopy, that's fine. I just wanted to tell you that tubal surgical interventions, most of the occasions, most of the infertility specialists will agree that it doesn't give very good prognosis, including proximal tubal cannulations. We have a large series of patients we did on proximal tubal cannulations, which didn't give us good results. And nowadays, the IVF success rate is going up only because of the fact that that is much more advanced in technology and the success rate is better. So that is one point. Second point is you talked about the ovarian function assessment, in which what are the factors that you would like to take into account along with the central follicular count. You said about antral follicular count. What are the other investigations that will point towards the ovarian?
Biochemical investigation. It's okay.
So anti-Mullerian AMH, we will go for
What is the normal
AMH.
range? What is the normal
So
range or the range you
it's from
expect?
0.7
0.7 to 3.5.
5
Okay. Was it done in this patient?
Yes, sir.
Yes, sir.
How much was the value?
1.2 nanogram per day.
Okay, so are you happy with that? So this
So
is the way
it's-
that you need to focus your attention to the ovarian problems, to the tubal problems in a history suggestive of this case. Okay. So if you are happy with the ovarian function, then you gradually shift towards the tubal factors, because it will take some time. Okay. And with all these tubal factors that we have discussed, I think IVF stands out as good, but only point of issue is that whether we should go for a prolonged medical treatment, antituberculous drugs in this patient, and that I suggest in consultation with the chest physician or a tuberculosis specialist, that will be better.
Okay,
Is it okay? So I think the medical management is most important. As Dr. Reddy pointed out, surgical intervention following the treatment of tuberculosis doesn't produce very good results. And it may lead to fistula formation, abscess formation, etc., etc. And so therefore, you need to be very, very careful about the medical management, for a prolonged medical management maybe, and then you go for the medical management like COH and IUI.
Okay, sir.
So with that, I'd like to close this with any input from any of the other teachers. Dr. Doshi, I can see Haresh Doshi, you are there.
Yeah. Sir, I just wanted to add one thing.
Yes, Kalpana, yes.
Yeah. They said that menstrual blood was positive for COX, right? So if there was some evidence of COX in menstrual blood, then I think laparoscopy should not be done, because it can
Correct.
spread the infection. So
Absolutely.
once we have got a supportive evidence for COX, then further testing like these kind of HSG or laparoscopy should be avoided.
Should not be there, yes. Correct. I agree with you.
Itself, they should have taken the endometrial biopsy to prove, to exclude whether there is endometrial tuberculosis there or not. Then only they can do the HSG, other things. In suspected case, we should not go on for this.
Dr. Haresh Doshi, any comment, or Dr. Kuldeep Jain, any comments? Then I'll close this case and go for the second case.
And Dr. Ashish, I'm Dr. Padmaja here.
Oh, yes, Dr. Padmaja. How can I forget you? Yes, Dr. Padmaja.
No, when they were talking about the ultrasound, I wish the PGs will visualize how you're going to see and tell the findings.
Correct,
Because ultrasound is like the third eye for the gynecologist.
Right,
Our ultrasounds we should be doing. So Akanksha Anjali, you present the case well, but when you're talking about ultrasound, you should be very comprehensive. I'm going to insert a lubricated condom, transvaginal probe in, and you're going to keep your eyes on the screen as you're inserting the probe, because if you're suspecting PID, there will be immediate tenderness. As you're going in, you will see a lot of free fluid.
Yeah, they are very conversant with the live Facebook, but not very conversant with the live transvaginal ultrasound. That is right, Dr. Padmaja. It's very important.
So look at the direction of the cervical canal, look at the cervical mucus, look at the uterus, because if it is a PID, if there are adhesions, it's going to be a fixed one. You look at the uterine myometrium, endomyometrial junction, look at the endometrial pattern. With the day of the period, you should be correlating that. Look at the tubes you will not see unless they're having a hydrosalpinx, but look at the position of the ovary, look whether it is adherent to the uterus, see for the sliding sign, magnify it, look at the stroma of the ovary, look at the follicles, look at the distribution. So you should be able to tell all these, because what we are looking for in a case presentation is how diligently you're working up to get as much information from as little as possible. So we're not going to tell that we're going to do all the TLC, DLC and things like that. So you should get information.
We're absolutely correct, Dr. Padmaja. As you correctly pointed out, that ultrasound is a third eye for the gynecologist. And TBS has become one of the most important weapons in diagnosing any pelvic pathology or even physiology. So I think that they should learn this. It is our deficiency that we haven't been able to transfer this knowledge, of immense amount of knowledge that the transvaginal sonography can give to a gynecologist. And even today, we refer the cases to a sonologist who has little idea about the pelvic, distribution of pathology and physiology. And therefore, it's a vivid description that you gave. Thank you very much, Dr. Padmaja. So,
and one more thing, sir, chest X-ray and all, if she is not having any respiratory symptoms, I feel we are wasting resources. Montus also is such a non-specific test. So in your order of investigations, you should tell what you think will pick up more and then the other things. Thank
correct.
you.
There is, yes, Dr. Padmaja, I agree with you partly, but there is some controversy about some of the physicians who agree that, yes, chest X-ray should be done, but then we have to remember that chest X-ray is usually normal because the primary complex that has happened in the childhood that has healed in the process, and nothing is visible in the chest X-ray, how much of a good resolution may be. So I agree with you, but then yes, they should focus more on the investigations like transvaginal sonography, like for instance, this, yes, MANTU is also this thing a problematic. And even today, the CV0 is also been put to the question these days. So I think it's a kind of composite effort to diagnose a case of pelvic inflammatory disease or tuberculosis, particularly in a case of infertility. I think students should be aware of that. It's a difficult case, I agree. But then how focused they are, that will be that we can find out from the cases. Any other input from anybody? Dr. Doshi, you are silent for a long time, which is unusual. Dr. Harish Doshi, has he left in the right direction?
No, I just want to add here for
Yes,
the
Kumar.
see when we are seeing a patient, we should directly hit for the diagnosis. We should not roam around. And Montus are such a non-specific test. It should not be on the priority. And we should try to obtain, as Dr. Reddy has also said, we should try to obtain histopath diagnosis or endometrial biopsy, or we should go for other direct testing. Rather, we should go for Montu test. And if patient has pulmonary tuberculosis, then her chest X-ray will be positive. If we are not suspecting pulmonary tuberculosis and we are looking for extragenital tuberculosis, then our workup should be on the different line. So X-ray test again will be a supportive evidence.
I just have 2 points on this. Number one, that the endometrial tuberculosis may not be positive in 50% of cases. That is one point.
Yes.
And the second thing is that pulmonary tuberculosis may be, silent in such a way that in a growing phase of life, she has missed that. And then therefore, I think there are some controversies on these issues that yes, what you said, chest X-ray, Mantu test, they are unproductive tests. They're unproductive tests. And by chance, if you miss it, then some of the examiners amongst us only, they will raise objection. So I think students are authorized to mention them, but with the caution that these are bound to be,
Yes, agreed. Yes.
Just
sir.
one point.
Yes, Dr.
Just one point regarding the surgical management, because there was a lot of discussion on the surgical management in this particular case, which is having tuberculosis. Role of surgical management in tubercular patient, whether it is endometrial tuberculosis or tubal block, is very, very limited, and one should be very, very cautious about the outcome of the surgical management.
Yes, we discussed that, Kuldeep. Yes.
In this patient, when your AMH, you are saying it is 1.2. So surgical management in tuberculosis is very, very limited, and it is just to enhance the chances of success in IVF. So that is to be taken into account. If there is endometrial factor, your histoscopy will be a boon for these patients. You can correct a lot of endometrial factor. Even if they are of tubercular origin, they should be, all patients actually, they should be put in a hysteroscope, and endometrial factor, if any, they need to be corrected before going for IVF. Second thing, if you are having a visible, what you call hydrosalpinx on ultrasound, you have to correct you have to delink or do the salpingectomy before going to IVF. corrective surgery, tubal surgery is very having very limited role, and one should digest doing the tubal surgery in tubercular patients, confirmed tubercular patient, because that will increase the chances of the interval between the treatment and the conception interval. At the same time, will increase the chances of complication. So I think role of surgery is very defined in tuberculosis patients.
Thank you, Dr. Kuldeep, for very good inputs, which essentially means that, I mean, the PG students, a good message from Dr. Kuldeep Jain is that, you see, there are two things. One is that removal of the bad factor, that is a tube which is affected with hydrosalpinge, removal of that actually increases the, improves the prognosis in a case of infertility, that we agree. But if you talk about the other part, that means the corrective tubal surgery, like the mid-segment block or the proximal tubal block, in a case of tuberculosis or even distal blocks, I think they are very poor prognosis they will lead to. So I think if you have to have a surgery, you have to think twice or thrice in a patient suffering from tuberculosis. First of all, I doubt whether anybody is very sure about the completion of medical treatment or not. That's a very important issue. And then after that, even if you want to have some surgical management for the residual management of the infertility, then I think these inputs are very important, that whether it is going to do very good for the patient or it is making a worse situation. Thank you very much, Kuldeep. And I would like to close this case discussion now, and I'll ask the second case presentation to happen now. Yes, Dr. Kumar, Dr. Ashok Kumar. Yes, sir. I think we can start with the second case because we're already running late now.
Yes, sir. Thanks for this case discussion. I request the faculty to stay and give your inputs for the second case also. So we will have the now second case and Dr. Nikita will be there to present her case. You can, and we have our faculty, Dr. Kuldeep Jain, Dr. Mala, Dr. Sanjeeva Reddy, Dr. Ashish, all are here, Dr. Archana, Dr. Kalpana, all are here. So we can start with our case, and meanwhile you start sharing your screen, Dr. Nikita.
Yes, sir. Sir, is it visible, sir?
Yeah, put it on the slideshow.
Yes, it is visible.
Yes,
Put it on the slideshow.
yes, sir. I'm doing it.
Yes.
Very good.
Good afternoon, sir and madam. Myself, Shweta Bharti from IJMS Patna. I'm going to present a case of male infertility. Here is a Mr. Y, 30-year-old Hindu male, businessman by occupation, resident of Champaran district, Bihar, married for 5 years, presented on 5th December 2022 to IJMS with the chief complaint of inability to procreate since 5 years. History of presenting complaint. Couple has been trying to conceive for the past 5 years. There is no history of consanguinity. Patient gives history of having done semen analysis 1 month back at a local hospital, which revealed no sperms in the ejaculate and was referred for further evaluation. There is no history of mumps, tuberculosis, or sexually transmitted diseases. No history of medical disorders such as diabetes mellitus, hypertension, thyroid disorder, epilepsy, or cardiovascular disease. There is also no history of any chronic drug use, no history of radiotherapy or chemotherapy. No history of trauma, torsion, or injury to scrotum or testes. There is no history of undescended testes, prior hernia or hydrocele or varicocele surgery. Personal history. He takes a mixed diet, sleep and appetite are normal. He is a chronic smoker and alcoholic since 10 years. He smokes around 5 to 6 cigarettes per day and consumes alcohol 1 to 2 times per week. There is no history of illicit drug uses. His bladder and bowel habits are regular. There is no history of occupational exposure to excessive heat, chemicals, pesticides, and radiations. Family history. There is no history of any kind of medical disorder in parents. No history of infertility in parents or first-degree relatives. Sexual history. Couple has been in healthy heterosexual monogamous relationship since 5 years. They are aware of fertile period. Coital frequency is 2 to 3 times per week with vaginal intercourse, and there is no coital problem. Masturbation, libido, erection, and ejaculations are normal. There is no history of any kind of lubricants or use of any contraceptive methods. Female partner's history. She is 26-year-old nulligravida. Her menstrual cycles are regular for 3 to 4 days every month with moderate flow. There is no significant past medical history such as diabetes mellitus, hypertension, thyroid disorder, tuberculosis, epilepsy, or cardiovascular disease. There is a past medical history. She underwent laparoscopy in November 2022. Age, HSG done was showing bilateral tubal blockage. Chromoperturbation was done with confirmed bilateral block. Past infertility treatment is nil apart from laparoscopic chromoperturbation.
Good afternoon, respected teachers. Myself, Dr. Nikita, I'll be continuing this presentation. General examination of the male. He has a male body habitus, moderately built, and he's well androgenized. No pallor or pedal edema, cyanosis, clubbing, or generalized lymphadenopathy noted. His height is 169 centimeters. He weighs 70 kgs. BMI is around 24.5 kg per meter square. Pulse is 88 beats per minute. Blood pressure is 120 by 70 mmHg. Thyroid examination is clinically normal, and there was no evidence of gynecomastia. Systemic examination, CVS, S1 and S2 heard. There were no murmurs. Respiratory system revealed normal vesicular breath sounds. Abdominal examination, soft, non-tender, no palpable mass, and no scars, and hernial orifices were free. Genital examination, coming to inspection, the pubic hairs were normal in distribution. Inguinal area appears normal on both the sides. External urethral meatus is present at the tip of the glans and in normal position. Penis has normal angulation and curvature. Bilaterally, testes were fully descended. Scrotum, rugae were present and pigmented, and no scars seen. There was no evidence of any hydrocele. Palpation. Testis on the left side measured 12 cc, while on the right side measured 15 cc by Prader orthodometer. Consistency, bilaterally they were firm, and tenderness was absent bilaterally. Epididymis size was normal bilaterally, and no tenderness was seen bilaterally. Vas difference was palpable bilaterally, and there was no evidence of any varicocele bilaterally. Per rectal examination revealed no prostatomegaly or no evidence of any enlargement of seminal vesicles was noted. So summary, 30-year-old male partner married to 26-year-old female for 5 years, presented with primary infertility with semen analysis done outside showing azoospermia. Couple give no history of sexual dysfunction. Male is a chronic smoker and alcoholic since 10 years, whose genital examination revealed firm and small sized testes bilaterally. Vas difference was palpable bilaterally. Examination of epididymis, prostate, and seminal vesicles revealed no abnormalities. Female had bilateral tubal block on HSG, which was confirmed on laparoscopy. Provisional diagnosis, a couple, 30-year-old male married to 26-year-old female with primary infertility with azoospermia, and female having bilateral tubal block. His investigations, we had done a repeat semen analysis at our setup, which showed volume of 2 ml, liquefaction and viscosity were normal, pH was alkaline, fructose is positive, and no sperms were found even on centrifugation. His FSH was 11, serum which was elevated, serum testosterone was decreased to 10 nanogram per deciliter, and LH was in the normal range, 6.5 milli international units per ml. TSH RBS was normal, serology was non-reactive. We had done his karyotype, which was normal, and it was 46XY. Thank you.
So what do you think is the cause of azoospermia in this particular case? What is your provisional diagnosis?
Ma'am, we suspect non-obstructive azoospermia in this case, ma'am, because the on examination, the testes were small in size, and there was no obstructive features noted. such as the seminal vesicle examination, parectal exam, which was done by parectal examination was normal. So, and even the semen analysis report showed normal volume, normal pH, and positive fructose. So we are suspecting non-obstructive azoospermia in this patient.
Why not obstructive azoospermia?
Stop sharing.
Yes.
Why not obstructive azoospermia? What leads you to think giving a straightway diagnosis to non-obstructive azoospermia?
Sir, his vast difference was palpable, and parectal examination showed no, epididymis.
Enlargement of epididymis.
What about the I come back to the normal evaluation, physical evaluation again to this patient. What is the normal testicular volume?
So normal is around 15 to 20, sir.
15 to
20.
In this one side was 15 and one
so
was
here in your history you have said one was 12 to 15, other was 15 to 20.
Yes, sir.
Okay. According to your definition, testis is normal. One side is normal, one side is little small. What else? Why you are thinking this is non-obstructive azoospermia?
Sir, on examination, vast difference was
palpable. You have not commented on epididymis.
Yes, sir. Epididymis was normal in size, sir. There was no enlargement of epididymis.
Okay. So what make you think this is non-obstructive azoospermia?
Sir, even on semen analysis report, the volume of the semen was normal. There was it was alkaline pH. Normally in obstructive azoospermia cases, we find pH is acidic because largely it is constituted by prostatic secretions, and low volume is seen on semen analysis, and also the fructose is negative usually in obstructive cases. Sir.
No, it is depending upon the site of obstruction only you will get all those things. It is not every patient obstructive azoospermia you will get.
If you are depending your diagnosis on fructose, then the discussion goes on that side, as Dr. Reddy has already said.
Yes.
How fructose is going to help you in your management and making the diagnosis?
So the fructose positive is usually seen in non-obstructive cases, sir. But usually, sir, and fructose negative is seen like seminal vesicles contribution is there, sir, in fructose. If fructose is positive.
So presence of fructose does not exclude anything. It just tells you where is the obstruction. Okay.
Yes. Okay.
So it doesn't tell you whether it is a obstructive azoospermia per se or a pure non-obstructive azoospermia. Okay. It is just going to presence and presence of fructose will just tell you where is the blockade. Okay. So that is not going to help you much in making the diagnosis. That will help you making the site of obstruction maybe coming into picture. So what else? What else?
Sir,
so let us go back to your examination only. What are the point against non-obstructive azoospermia?
Normal size against non-obstructive. One side of the testis is normal in size, sir.
See, you are making the diagnosis on the basis of two things. One is the examination, and other is the your investigation. Okay. So at present, I am discussing the examination part. Okay. In examination, what is the difference between the testes of a non-obstructive azoospermia and a obstructive azoospermia?
In non-obstructive azoospermia, usually the testis size is smaller, sir. In obstructive azoospermia, it is normal in size.
Okay. When you say the size, again, is there any grading like at one point of time, you will be very sure that it is non-obstructive azoospermia. There are certain borderline cases, and there are certain which are mixed, which are having mixed problem. Like there is a obstruction also, and it is non-obstructive factor also. So there is a full spectrum. What about the size? When you speak about the size, is it 50% of the normal makes
Less
you
than
feel
10
that it is
cc or less
non-obstructive azoospermia?
Less than 10 cc, it is severely atrophic, sir.
Because your patient is a borderline case, basically.
Yes.
One side size is 10 or 12, you have said. Other
12.
size is just normal.
Yes.
So in this type of cases, one is the size of the testes. What else? What else? When you are palpating the testes, what else you will look so you can make your diagnosis?
The epididymis, sir. Epididymis.
No, we are just focusing at testes at
Yes.
present. Epididymis will come later.
Consistency, sir. Whether it is
Consistency.
soft.
Okay.
If it is soft,
So
that means
consistency, in your case, it is firm.
yes.
Okay. So why you made the diagnosis of non-obstructive azoospermia? In non-obstructive azoospermia, what is the consistency?
Soft. Soft.
It is soft.
Yes.
So your diagnosis is wrong. Number one, if you base your diagnosis on the basis of palpation, okay, you are saying it is a normal, borderline normal volume, consistency is firm. Coming on to the epididymis, what all you will see in epididymis to make the diagnosis?
Epididymis enlargement, sir, and fullness of epididymis.
Yeah.
Is it
so
full
fullness
and
of see, it should be palpable. If
Yes.
it is palpable normally and it is full, what will be the information? Out of
somewhere
it?
it's obstructive types.
So it becomes a obstructive. So if your case was little incomplete. Okay, epididymis has to be into the picture.
Sir, I have mentioned, sir.
Okay.
Epididymis not.
Epididymis was normal. Again, it goes in the favor of obstructive azoospermia, not in favor of non-obstructive azoospermia. Now coming on to the investigation. Apart from that,
Sir, we can do
investigation-
transrectal ultrasound can be done, sir. Transrectal ultrasound, and the gold standard would be testicular biopsy, sir, to diagnose.
you are moving too fast.
Yes.
From the history itself, history and
From
exam.
history, you have just gone to testicular biopsy. That is not the way you should discuss. Coming on to the what you call investigation. Okay, semen analysis you have done twice, thrice. You have done pelleting. Why pelleting? Why you have mentioned the pelleting?
Sir, this is azoospermia definition is two centrifuge samples at least 2 weeks apart, showing no sperms even on centrifugation. So that's why we have centrifuged.
Okay. Why you are not kept the diagnosis as retrograde ejaculation? Why it is not retrograde ejaculation?
Sir, in retrograde ejaculation, patient usually gives history of passage of cloudy urine after ejaculation, but he's not giving any history here. And again, in retrograde ejaculation, we see low volume and absence of fructose, sir, in retrograde ejaculation. So that history.
Absence of fructose, why?
So it is completely going into the bladder. I mean, it might be in partial retrograde ejaculation, we can see fructose.
Fructose absence and presence may not tell you about the problem of retrograde ejaculation. Volume is one. Volume
is, yes, sir.
Volume is one. And see, again here, you said it is non-obstructive azoospermia. Volume is normal. Usually in non-obstructive azoospermia, volume will be slightly lower side. In retrograde ejaculation, again, the volume, if you are finding any patient with very low volume, retrograde ejaculation has to be ruled out in azoospermic cases. That is, and what else? What else in the history? For retrograde ejaculation.
Retrograde ejaculation. That that's he doesn't give any history of cloudy urine after ejaculation.
That
sir,
is
and-
okay. That is okay. Don't repeat whatever
And,
you have told.
Sir, even in retrograde ejaculation also, his testis will be normal in size. But here we are finding that one side it is little reduced.
No, history of anejaculation. Many of these patients, they give history of anejaculation, and again, low volume anejaculation. These are the things which you have to keep in mind when you are suspecting retrograde ejaculation. Okay, so leave aside that. Next investigation, you told FSH. Okay.
Yes.
Now, how FSH can help you in making the diagnosis?
Sir, actually, they in obstructive and non-obstructive azoospermia cases, there can be quite a bit of overlap, sir, in hormone profile. So even in obstructive cases, usually FSH, LH, and testosterone will be in normal range. But in non-obstructive azoospermia cases also, FSH can be high or normal, LH can be high or normal, and testosterone can be less or normal. So only on the basis of hormone analysis, we cannot come to a diagnosis unless and until it is grossly FSH and LH are grossly elevated and testosterone is in the low range.
What is the normal? What is the normal FSH?
So 7.6 to 8, sir.
Any comment from faculty? Any faculty? See, up to normal. See, when we talk of normal, 10 is taken as normal. Okay, it is not 8. 10 is taken as normal, and whenever it is borderline, it is better to look at the lab because that is one thing which is very important. And most of the labs, they are not calibrated for this type of investigation. So whenever there is a borderline report, like in your case, it is 11. Okay,
Yes.
so it becomes borderline. Your patient is looking like a obstructive azoospermia as per the history is suggestive. Okay, so in these type of patients, it is always better to go for a repeat hormonal assay to make the diagnosis. Now coming on to the what happens to FSH in obstructive azoospermia?
It is normal, sir.
It is normal. Okay, so in your case, it is just borderline. Again, there are certain patients which are having this type of picture, but it is again can be discussed at a later stage. What happens to FSH in non-obstructive azoospermia?
It is elevated, or it can also be normal, sir. I mean, it can be normal or elevated.
Normal in which cases? If it is a non-obstructive azoospermia, which cases you will find the normal FSH? What type of cases?
So recent onset testicular failure, they will have normal FSH levels. Like recent onset of any infectious cause which is causing testicular damage, or any recent insult.
Okay, but usually these patients who are having non-obstructive azoospermia, they will have a high basal high FSH and LH. Okay.
Yes.
So what next? How will you confirm your diagnosis?
Sir, clinically, because bilaterally VAS difference was palpable here in this case, I would not go ahead with transrectal ultrasound because there was no clinical features of obstruction in my case. So, and the confirmative would be testicular biopsy and to freeze any sperms, whatever we are retrieving for further use.
No, again, when we talk of confirmation, we need to restrict ourselves to non-invasive first, and then we move on to invasive. Okay. Do you order testicular biopsy in all these cases, or any other investigation you will like to do? What was the karyotyping in this case?
Yes, sir. Karyotyping was normal, sir. 46XY, it was normal, sir. We have to
46XY. So only karyotyping this type of report is okay, or you will go for any further genetic testing before you put the patient put individual into the testing?
Yes. In non-obstructive azoospermia, we should also see for AZF mutations, sir. We should see in which region the mutations are there. Like,
So what are the 3 types of mutations in azoospermia factor, and in which can you hope to get sperms?
ma'am, there are 3 types of mutations: AZF-A region mutations, AZF-B region mutations, and AZF-C region mutations. In AZF-A mutations are very less. They constitute only up to 5% of the cases, and usually we see here Sertoli cell only syndrome type of cases. Whereas AZF-B and AZF-B plus C region mutations constitute about 15% of the cases, and here we can usually see sperms arrested. Maturation arrest is seen in these cases, and AZF-C deletions are the most common. They constitute up to 70% of the cases having bichromosome microdeletions, and in these cases we can expect up to 50 to 60% of sperm retrieval, surgical sperm retrieval in these cases, ma'am.
So the easy mnemonic is in C you can see. Okay. In C, you can do a testicular biopsy and you might see sperms. And one more thing I was thinking is you've not been talking about his smoking and alcohol history.
No,
So
he told
even
about the history, yes.
Yes, but we're not concentrating on that. So the thing is, when some people, it's not that they have to be a alcoholic who is drunk all the time for it to have an impact. It depends upon your genetic sensitivity. And one more thing you can do is you can see the testosterone estrogen ratio. In them, comparatively, you have a high estrogen. So that will have an impact, and their lifestyle modification will definitely I feel that we should intervene before we go ahead and do a testicular biopsy and try to freeze.
Okay, ma'am. Yes, ma'am. Actually, because
so
his BMI was in the normal range, we didn't proceed with estradiol, ma'am, in this case.
So coming back again to the further process. So you are having in your mind, it could be obstructive azoospermia or it could be non-obstructive azoospermia. How you are going to proceed?
Sir, in like genetic analysis, from the point of view of
genetic analysis is normal as you have already done. So how you are going to proceed further?
Sir, in this normally in non-obstructive azoospermia cases, because his testosterone level is low, so we have started him on medical management. Clomiphene citrate 25 mg OD was started. We would like to give him.
By medical management, what you are going to achieve from the medical management?
To optimize his testosterone levels to the range of 300 to 400.
May I intervene? Is he taking any drugs that can have effect on the?
No, ma'am. No, ma'am. He's not taking any testosterone or no steroid intake.
No recreational drugs he's taking.
No. We just wanted to improve his spermatogenesis by raising intratesticular testosterone, ma'am, by giving clomiphene citrate, so that his testosterone levels come to an optimum range of 300 to 400, so that during spermatogenesis, the sperm retrieval would become better. And whatever during testicular biopsy, whatever sperms we retrieve would be frozen and used for ICSI.
How long you are going to give clomiphene citrate?
Sir, minimum 3 months. And then we will repeat again, like monthly testosterone we can do, sir, and 3 months later we can repeat his semen analysis.
Do you think testosterone is the culprit here? Means that is the cause of azoospermia. How you are relating as far as the sexual history is concerned, it is normal.
Yes,
okay. The development part is normal. So I will look this isolated testosterone report with a pinch of salt.
Okay.
because it is this isolated testosterone deficiency is not really correlating with your picture. Okay, so again, I think before, because clomiphene citrate in this patient may not be able to help you much. You will be wasting time. But before that, starting the therapy, do these patients, they require some counseling from you, or you just start medication?
Sir, they do require counseling. Actually, we counsel them that it can be even due to genetic causes, which is causing this this problem. So we have to rule out Klinefelter syndrome, so that because this syndrome has health implications in the male in future. So
that
and
you
also,
have already ruled out. Now now patient is asking how I can get the pregnancy.
yes,
Okay.
sir. So we will tell him that
Does serum prolactin has any role?
prolactin in cases of hypogonadotropic hypogonadism, prolactin is recommended, ma'am.
No. Have you done the serum? We have not done serum prolactin in this particular case.
Yes, ma'am. Because it was rather of hypergonadotropic hypogonadism, we have excluded that one. Prolactin investigation has been excluded. Also, we will counsel the man that if he is having AZF-C region mutations, then the chances of sperm retrieval would be maximum, but that would be transmitted to his male offspring if he is going to have a male child. And if it is a female, there's not going to be any genetic, implications, health implications in the female, or any infertility implications in the female. That counseling you would do, sir.
He is a young patient. He has come to you for treatment. Okay. And his main aim is to achieve a pregnancy.
Yes.
Now, once you have done so many tests and all that, he is going to ask you what next. Okay. So what are the options you will discuss with the patient? What are the options available, and what type of counseling should go into such type of patient to decide, to help him decide to get the treatment further?
Sir, we would counsel the patient that in non-obstructive cases compared to obstructive cases, the chances of
He is not bothered. He is not bothered about whether it is obstructive or non-obstructive. He is just asking you how I can get the pregnancy.
So we would explain him about surgical sperm retrieval, sir. The option of surgical sperm retrieval would be explained to him, but he would be counseled that we might not be able to retrieve sperms altogether also in some cases. So in that cases, he should, if they are retrieved, we would be freezing them for future use. And if we are not able to retrieve, we can go ahead with donor sperm. And because in this case,
he is going to ask you, Doctor Saab, mere ko nahi malum. I have spent so much money in the testing, and now you are saying you might get it or not. What are the chances in getting? So with this type of report, how you are going to counsel? Report is with you. Now patient is sitting in front of you. How you are going to counsel, how many, because he will understand only the language of percentage. Okay.
Yes.
So how, with your report, what are the chances of getting a sperm in surgical retrieval? That you have to tell him.
Yes.
So he can decide.
So 35 to 40% chances, 50% chance can
Now
be
coming on again, have you made the diagnosis? Whether it is obstructive azoospermia or non-obstructive azoospermia?
Yes, sir.
What is your diagnosis?
Non-obstructive azoospermia, sir.
So you are sticking to non-obstructive azoospermia.
Yes, sir.
But it is looking
Borderline.
the otherwise. It is more of a obstructive azoospermia than the non-obstructive azoospermia.
In obstructive azoospermia cases, the chances of sperm retrieval are very high, sir. 90 to 95% chance of sperm retrieval is there.
Okay. So suppose it is, now you have made my mind non-obstructive azoospermia. Now looking at this report, I go with your diagnosis. It is non-obstructive azoospermia. Now how much is the chances in this patient that you will get a sperm?
40 to 50% with microtesis, sir.
40 to 50%. Okay, so how you reach to this 40 to 50%?
Sir,
On what
usually,
basis? On what basis?
sir, it is only on like prior if genetic testing is done and we know the mutation, where in which region the mutation. Suppose he's a carrier of Y chromosome microdeletion, and we know the mutation is in AZFC region, then we can expect 50% success of retrieval, sir. But if it is due to any other, like suppose his hormone analysis is showing, I mean, it is in frank testicular failure. I mean, then it is due to some other causes. Then we might expect a little bit lesser.
Can FSH guide you in deciding the retrieval rate? Is
No,
there
no, sir.
anything
No.
like that?
No, sir. No, sir. Studies have proved that FSH does not play a role in microtessay. Whatever may be the FSH level, microtessay will not affect the retrieval rates.
So you are going directly for microtessay. How many microtessay? How many? Do you know what is microtessay?
Sir, in microtessay, the skin, datos, and tunica vaginalis and albuginia are cut, and then the testis and the epididymis testis is, I mean, delivered out, and then under magnification, the seminiferous tubules are located. The dilated seminiferous tubules are taken, and their enzymatic degradation is done or mechanical.
So microtessay, in your thinking, microtessay is the only option for him?
No, sir. Tessay can also be done.
So why you are just jumping on? Because see, you have to be little realistic. Microtessay, if you see all over India, it is not available at 95%. 95, where rather 98% of the center. Okay.
Yes.
These patients, they are available in each and every clinic.
Yes.
So microtessay is one thing which is actually should not come into discussion at this point of time. Anyway, there are a lot of options to these patients. Only what I wanted to ask you, FSH level does help in prognosticating non-obstructive azoospermia, sperm retrieval. There is a very large study which is done, which has come out in favor of prognostication on the basis of FSH. Okay. So if the FSH level is 11 to 15, okay, there are very good chances that you may get a usable sperm in that case, and that is how you have to counsel. Okay, the patient is going to ask how much chances are there. So there are very bright chances of getting, see, it is not only FSH level, it is firm testes. Okay.
Yes.
So if it is firm testes, FSH level are borderline, you are having very good chance. So you can counsel your patient that yes, we are having very good chance on these two reports, on the basis of these two reports. Then 15 to 30, there are borderline chances. You should give guarded prognosis, whether you are doing microtessay, tessay, or open tessay, whatever you are doing, guarded prognosis should be given. And more than 30, even if you are doing microtessay, there are very, very poor chance of getting a usable sperm. Okay, so that is how you take your basic investigation like palpation as well as FSH in giving the counseling in detail to the patient. Another counseling which is important is the cost. You may be having microtessay, but patient is not having money. Okay. So you have to see that also, because cost is involved in these investigations. So unnecessarily you should not waste your time. So what is the other option for this patient? If patient can't afford, what is the other option in this patient?
If patient can't afford tessay or microtessay, we can go ahead with donor sperm.
donor insemination.
Yes,
Okay, that is very good. And you should always keep in mind the option of donor insemination in azoospermia when you don't have money,
yes,
you don't have sperm, in spite of doing micro-TSA, as you said, you may not get a sperm. Donor insemination should always be discussed in these patients. Okay. Now, coming on to the female side, you said that tubes are blocked.
yes, sir.
Okay. Patient can't afford your PISA or TISA, whatever you are saying. What are the options further in this patient?
Sir, IVF with donor semen, sir, because her tubes are blocked.
Patient can't afford IVF.
IVF. Then adoption, sir. And
No, so again, coming back to the previous, see, tubal factor doesn't mean that you can't offer surgery. Okay. So if it is not a tubercular tube, you can certainly go for a corrective surgery. If it is, of course, again, the counseling is important in that patient. But again, these type of option you have to discuss, keeping in mind both husband and wife. It is not only azoospermia, it is the female factor also, which you have to take. So why I brought this point, it is whether it is a female factor or male factor, the counseling has to be done, keeping in mind both the options. Any other questions from anyone? I think I had tried to finish the discussion and taking to a logical conclusion, but yes, it is open again.
Basically, this patient has azoospermia with the borderline hormone levels, and you have ruled out the genetic cause.
yes,
So when you take a male infertility into account, you have to focus on three major factors. One is the ejaculatory or erectile dysfunction, which this patient doesn't have. Second is sperm production defects, where patient may have oligospermia or azoospermia or cryptospermia. And third may be the motility or the functional defects in the sperms. So these are the three main factors, categorically three main factors. There can be other factors for male infertility, but these are the main three factors. Dr. Kuldeep Jain has already told you how to arrive at a diagnosis when you get a patient of azoospermia. But when you have other cases like sperm production defect, your case is a case of sperm production defect or sperm retrieval defect, whatever you say, the patient showing semen analysis of azoospermia. So you have to categorize whether it is pre-testicular cause, testicular cause, or post-testicular cause. Post-testicular cause definitely is obstructive. Pre-testicular may be pituitary causes, where your hormones will help you, where everything is low, FSH, LH, testosterone, everything is low.
yes,
So in that case, your gonadotropins can help straight away and improve the quality of the sperm. And definitely when you have this azoospermia, which is a testicular cause we are thinking of, testicular cause or non-obstructive cause of azoospermia, there one big chunk is of the idiopathic cause.
yes,
Where you don't find any cause. Then there is, of course, genetic, obesity, and environmental. Now, this patient has a history of smoking.
yes,
Maybe he's having a habit of recreational drugs, which can have the effect on the sperm quality. Sometimes some degrees of varicocele also can affect the testicular cause.
yes,
And definitely these patients may be taking some drug which can cause sperm defect, production defect. So
yes,
you have to think in those cases. And whenever you're counseling a patient of male infertility, you have to make both the husband and the wife sit together and then counsel. Counseling is very important. As your female partner also have some problem, subfertility problem, tubal factor, and the male has also have a factor of azoospermia. So definitely your counsel has to include both the partners. You have to discuss with them the options, and maybe lifestyle modification can help, but then looking at the female partner is having tubal block,
Yes.
and the male is having azoospermia. So improving the sperm count may not help to get the pregnancy. You have to think of things like IVF and maybe ICSI in this particular case.
Yes.
So you have
another important thing which is missed. Actually, the Dr. Mala pointed out. Many patients who are having a transient azoospermia, and that is because of, and your patient might fit into that category. You have to take a history whether patient is going on a gym, and they are usually, when they are exposed to rigorous exercises for a longer period, they are taking some supplements also there, and that may be the only reason to have testicular insult, and that history needs to be taken. Any history of recent viral fever, a simple viral fever can have insult on the testes and can cause transient azoospermia. Okay, so these things need to be kept in mind before putting a needle or something like there. Now coming back onto two things, hypogonadotropic hypogonadism. Okay.
Yes.
Now again, these patients, what will be the examination if your patient is hypogonadotropic hypogonadism, and how you are going to treat them?
Sir, on examination, they will have decreased androgenization. That is, they will be having less facial hair, pubic hair, and also they will show small testicular volume bilaterally, and that's so. This is the examination part, sir.
No, it is not complete. I just told you it is not only the volume, it is the consistency which tells you.
Consistency also will be soft, sir, because there is no decreased spermatogenesis.
No, in hypogonadotropic hypogonadism, usually the consistency is firm, but it is small. Okay.
Yes,
So
okay,
small testes with firm consistency usually fits into hypogonadotropic hypogonadism and can be substantiated by your investigation. So when you are having a small testes but firm, it is in favor of hypogonadotropic hypogonadism rather than a testicular insult. Okay.
Okay.
How you are going to, once you made the diagnosis of hypogonadotropic hypogonadism, how you are going to manage and how you are going to counsel. Again, before managing, counseling comes first. Okay. So how you will counsel this patient and what are the options available?
Sir, we would counsel them that there is a high probability that his spermatogenesis would return to a normal level. But the thing is that he would require prolonged treatment duration with injectables. So he has to be on follow-up for around 12 to 18 months usually. And he has to take injection.
Any role of oral medication like clomiphene citrate in hypogonadotropic hypogonadism?
No, sir. No, sir. Only
Okay.
gonadotropin should be given.
That is very important. That is very important that clomiphene, etc., will not work in these type of cases. So you are going to give a prolonged treatment. How prolonged?
Around 12 to 18 months, sir, usually.
12 to 18 months.
Yes.
What drugs you will give? What will be the dose?
Sir, in their ideal management where even pituitary is intact, it will be pulsatile GnRH.
I don't want theory. Don't want theory.
Okay. So
because pulsatile GnRH analog has gone into the down. So what is practical?
Sir, in post-pubertal onset of hypo, we can give HCG alone can initiate spermatogenesis, sir, in most cases. So HCG 2500 international units biweekly or recombinant HCG 250 micrograms weekly for 3 months. And then we can repeat his serum testosterone levels, sir, and see whether
What is the problem with recombinant? And what is the advantage of recombinant?
Advantage is that it is there's no batch to batch variation, sir. I mean, it has a good efficiency, and disadvantage I'm not sure.
Disadvantage, you have to see the pocket of the patient.
Yes, sir. It is cost. It is
very, very costly. You are going to prescribe 12 months,
yes,
18 months. Patient may, because see, you have to insist on these things that once you start, again the cost will come. Hypogonadotropic, you have given him the treatment line, but most of the patients, they drop in between. Okay. They drop in between just because of the cost. They cannot carry on your treatment.
Yes, sir.
Okay. So before starting any injection, you have to ask the patient whether you are comfortable in at least 12 months is a very long time, but at least for 6 months to get something out of it. Okay.
Yes.
It may be 6 to 12 months, but if the patient is not willing to go for that type of treatment, then it doesn't work in these patients. Okay. So major disadvantage of recombinant is cost, and as far as the efficacy is concerned, both works. So it is not like the urinary will not work.
Yes.
Most of the time, in 100% of the patient, it is urinary which is working. Okay.
Yes.
So recombinant is not necessary. It is having constraint. So you said SCG. What
Yes,
about other drugs?
So recombinant FSH or highly purified HMG can also be used if he's not responding adequately with HCG.
No, so you are going to give FSH or combination of FSH LH. What is preferable?
HMG, sir.
Yes, so it is not only FSH, you require a combination, and urinary product, they work well.
Yes.
So they are cheaper also, and having a right amount of FSH LH. How frequently you give?
Thrice a week, sir. 75 to 150 international.
Okay. What is your endpoint?
Sir, if he is compliant, if his male is compliant, we can give even, I mean, till his spermatogenesis is restored to a good adequate level, and even the
What do you
serum
mean
test,
by good adequate level?
like his ejaculate is showing sperms. Sometimes they revert back completely, hypo patients. But in some people,
what will be your endpoint? Like you are looking at the normal report, or you are looking at the appearance of sperm? What is your cutoff?
10 millions per ml or and serum testosterone of range above 400 nanogram per deciliter.
No, you will be taking the semen analysis into consideration, or testosterone level into consideration?
Testosterone levels. Testosterone.
See, if there are few sperms in the semen and testosterone level is normal, you will stop the treatment.
We can go ahead with surgical sperm retrieval in these cases, sir. Suppose.
Why you are going for surgical? Means what is your aim? If you are having few sperms in the ejaculate, why you will go for surgical sperm retrieval?
Yes, sir. We can. We did
what
not.
Process you are planning? What process
we
you are planning for this patient?
ICSI we can plan, sir. If there are sperms, if we can retrieve few sperms, we can plan ICSI.
So your cutoff point will be, means there are two ways looking at it. If there is a tubal factor and other factor, patient is ready for the advanced procedure, you can minimize the duration of your treatment.
Yes,
So
sir.
once the sperm starts appearing in your semen, the patient can be offered a combination of HRT plus ART.
Yes,
Okay,
sir.
and
Yes.
that is now very common management of these patients. Initially, when the IVF was ICSI was not available, we used to give it to for a prolonged period. Okay, because the cost is again coming. Patients are not very compliant. So better way is once the enough number of sperms available for your procedure, ART, whether it is IUI or IVF ICSI, depending on the response, you can cut short the duration of your treatment to 3 months to 6 months and can offer a combination of ART. So that is how it is working. So there are 3 types of option: completely medical therapy for a very prolonged period, 12 to 18 months, and that might not work. Again, at the end of 12 months, you are having only few sperms. So again, patient has to go for ART.
Yes.
Okay. So
Yes,
to
sir.
minimize the duration, minimize the cost, you can look at the cutoff that once you get enough number of sperms for ICSI or IUI, you will stop further treatment. You can use these sperms, and usually it is preferred once you are having sperms available in these patients, you offer sperm freezing. Okay,
Yes.
you
Yes.
offer sperm freezing because once you stop the treatment, you can not continue treatment for very long. So you preserve the semen for future use. Okay.
Yes.
So
Yes.
sperm freezing is very important in these patients once you start having the sperm in ejaculate. Okay.
Yes, sir.
Another thing about the retrograde ejaculation. Okay, now this patient is having retrograde ejaculation. How you will confirm and how will you treat these patients?
Sir, confirmation is by examining the yes, sir, post-coital urine examination. We have to do collect the urine. Initially, we have to ask the patient to void and then give him sodium bicarbonate tablets, and then again masturbate, and then his urine, whatever is there, should be collected and centrifuged, sir. And then we should see if any sperms are there in the centrifuged sample.
Okay, so you are having sperms in the ejaculate. How you are going to use that?
Sir, if lot of sperms are available, we can do IUI. But in this patient, because the tubal blockade is there, we have to collect them, freeze them, and proceed with ICSI or IVF.
Okay. So this completes the retrograde ejaculation, azoospermia. Coming on to the idiopathic.
Yes.
Coming on to the idiopathic, what is the role of drugs in idiopathic azoospermia? Idiopathic oligosteroteratogespermia. Is there any role? What is the options available? How long it is to be given? What are the drugs to be given?
Sir,
And
there is
what are the options available to these patients? So coming on to the medical management first, is there any role of medicine? What are the medication you are going to give?
Sir, medications in idiopathic, we can give clomiphene citrate, 25 milligrams OD for 3 months, 3 to 6 months, sir. Or if the patient is obese, so we can give anastrozole, and the testosterone estradiol ratio is less than 10. There is a role of anastrozole or letrozole in these patients, sir. Anastrozole 1 milligram OD for 3 months, or letrozole 2.5 mg OD for 3 months. There is no role of gonadotropins in idiopathic male infertility, sir. And suppose
How long you are going to give, and what is the endpoint again?
3 to 6 months, sir. Maximum 6 months.
Okay, any, like, as you said, you will start clomiphene and all that. Depending on what are the criteria of starting these drugs like clomiphene, what is the criteria?
So mild idiopathic oats we can start, sir. Not very moderate.
Yeah,
Not very,
so moderate and severe, usually you should not give medical management. But any other drug you would like to
Sir.
prescribe
Yes,
to
sir.
this?
Antioxidants have a role, sir. Antioxidants, and if we are seeing excessive leukocytosis, like more than 1 million cells per ml, then we have to go ahead with antibiotics and anti-inflammatory agents also. And antioxidants definitely have a role, sir, especially if the sperm DNA fragmentation is high, or we are finding agglutinated specimens and low motility specimens. So in these cases, we can go ahead with antioxidants, anti-inflammatory, and antibiotics, if at all they are also showing leukocytosis.
No, this is the same patient is having, is coming with multiple reports, very variable, motility 10%, 15%, having lot of pus cells in the semen. How you are going to treat?
The semen culture can be done, sir, for adequate treatment. Semen culture, and depending on the culture sensitivity report, we can give antibiotics, empirical antibiotics.
Culture is coming negative.
Sir, if
you have done multiple cultures, they are all coming negative. How will you proceed?
some chlamydia and all that, it doesn't grow in culture, sir. So we can give levofloxacin or doxycycline can be given, so for 3 weeks, 3 to 4 weeks.
So that is very important. Whatever antibiotic you are giving, it should be given for a longer period.
Yes.
It should not be given for 7 days, 10 days, 15 days. Usually the culture comes negative in these patients.
Yes.
That is very, very important to understand. And at the same time, you can go for a urine culture. Urine culture might come positive.
Yes.
Semen culture is negative. Then you can take help of that urine culture. Second thing is sometimes you can do prostatic massage and send the ejaculate after prostatic massage. You might get a positive culture report. But if the culture is negative, doxycycline can be given for 3 to 4 weeks. Still there is lot of round cells seen. What will you do?
So round cells can be immature spermatids or even leukocytes.
No, you
So we
have confirmed that they are macrophages.
Okay, sir. So if there are lot of, then we can go for testicular sperms. We can go, like the sperm DNA fragmentation is very high even on treatment, and we are not seeing any improvement in his parameters. Then we can go for ICSI, sir, like ICSI or
no count has improved. Your motility has improved, but you are still seeing a lot of macrophages. What is the option available to these patients?
How is that morphology?
You can do the processing in the lab. You can get rid of the debris and you can reduce you can select the sperms by various methods and can go for IUI. That is a simple process. Okay, before moving on to the fancy treatment like ICSI and other thing. Okay, so you have to grade your patient. You have to be time bound. You cannot continue any drug or any procedure for a very long period. You have to counsel your patient very, very thoroughly. They should understand what you are going to do. Before putting a needle, you must counsel that how it is going to help, how
Sir, you're
it is
muted.
how it is going to help, and take patient in confidence. Whatever you are offering, it will help to the patient, but they should understand what all is going on. Your management of infertility has to be time bound. It cannot go on for years together.
Yes.
Anytime you see the patient, because they are very disturbed, they will come with so many reports every month, every 15 days they are getting it done. That is not required. That is not required. There will be variation that you have to tell the patient, choose a procedure which will help. Role of medication is very limited. Hypochondropic, certainly there is a role of medication.
Yes.
In high DNA fragmentation, certainly there is a role. In idiopathic, there is a limited role. So you have to quantify the problem and then offer the treatment in the patient. Many times you have to combine it with ART.
Yes.
That is very important. Okay.
Yes.
What is the role of surgery? Like I try to cover everything. Varicocele is left. So how you are going to diagnose varicocele? What are the indications of surgery, and how it is going to help?
Sir, varicocele is a clinical diagnosis. Only palpable varicoceles are significant. Subclinical or non-palpable varicoceles are usually shown not to have any effect on infertility, or they don't cause infertility, sir. So that is, regarding the treatment, I mean, those who patients who have not young patients who have varicocele of a short duration of a normal or minimally raised FSH levels and having a normal testicular volume, they are the best candidates to go ahead with varicocele surgery, especially if they are having abnormal semen parameters with high DFI, sperm DFI. A person who is having normal semen analysis need not go for any surgery, sir. And whenever there is no time constraint, I mean the patient is young and the female has no or very mild infertility, then varicocele surgery can be tried, sir, because even after surgery, the normal spermatogenesis will take around 3 to 6 months to the patient to have normal spermatogenesis. So if the time is not a constraint, if the female is having no other factor or very mild factor, and the varicocele is not of a long duration. Even if it is of a long duration, if suppose the person is having very high sperm DFI and previous attempts of ICSI or IVF have failed, then we have to go for surgery before planning the next cycle of ART.
Okay, one important thing is ultrasound is having very limited role.
Yes.
As far as the management is concerned. It can quantify, prognosticate, but as far as the management is concerned, so ultrasound role is limited. Right? Most of the patients, they are diagnosed varicocele on ultrasound, so that should not be the practice. It is the palpable varicocele which needs to be taken into account with abnormal semen parameters and no other female factor with and young patient. Okay.
Yes.
Second thing, before going to varicocelectomy, you must freeze sperm again, because many times after varicocelectomy, you may find a very compromised semen parameter, and so that care should be taken.
Okay.
Dr. Mala, any comment?
No, I think it has been a very comprehensive discussion, and our students presented really well.
Yeah, they were
Case
good.
presentation was really good. I must congratulate those girls for excellent presentation, and they have really discussed very well with all the questions that Dr. Kuldeep Jain raised. And this is how you attempt a case of male infertility, taking all the points into consideration and discussing all the points. The history is very important. Then comes the clinical examination, which has its own important points. And then comes the investigation and the rule of the investigation. And then patient at the end wants a treatment and the management. So whenever a case of azoospermia comes, you have to classify whether it's obstructive, non-obstructive, testicular, pre-testicular, or post-testicular, whichever way we want to do it, and do the comprehensive investigations and then do the management. I think it has been an excellent discussion.
Thank you.
Last thing is consent. Consent, informed consent, whatever you do, even for IUI, for donor insemination, everything you require a proper consent. And now with ART law coming into force, you have to be doubly sure that you have explained to the patient and you have taken the consent, whether it is IUI or IVF or PISA-TISA, whatever it is. Over to Dr. Ashok.
Lot of paperwork to be done, and these consents are very important.
Okay.
So is there any other query from Dr. Kalpana or any other person?
No, sir. First of all, I would like to congratulate Nikita and Shweta for presenting case in such a nice way and taking all the question in a very interesting way. And also, I would like to express my thanks to all the moderators, especially Kuldeep Jain sir and Mala ma'am, for their very informative input.
Any students, any query, you can put it in the chat box.
Yes, you can
so
put,
that we can answer them. If from the participant students, if there is any query, we can see the chat box and we can answer them. And Dr. Padmaja, any input from your side?
They presented the case very well, Dr. Ashok. So, and it is good that they put up the effort and to read up about it before they came and not just on an impulsive thing. So I think that they should be complimented for.
Thank you. Thank you. I just wanted to have, I think we have a few more minutes. Yes, few more minutes. Dr. Kuldeep Jain, you can directly give the students advice about in this modern era, one should go for surgical management if it is correctable, or straight away go for ART, IVF or ICSI or something.
Regarding the female infertility, you are saying?
Female as well as for male, like anastomosis and everything, one should go, or it should be just straight away go for the IVF, ICSI.
I think
this is a debatable point. That is what I'm asking.
Yes,
that
yes.
How the student should answer.
See, surgery cannot be avoided. Surgery has to be complementary to ART.
No, like the situation is, if there is a tubal block in female infertility, so straight away one should go for reanastomosis or straight away go for IVF. Don't attempt anastomosis, number one. Like for male infertility, if there is a block, one should try to do correction or straight away say, no, we will not go do for the correction. We will have the alternative non-surgical management.
Discussion with the patient.
You have to take 2-3 things when you are making a decision.
Yes, that is what I want to.
One is age of the female patient. That is very, very important. Even if you are able to correct the tubal defect, but if the age is 38 years, 40 years, you are not going to give a very, very good outcome in these patients. So age is one factor which needs to be taken into consideration. Second is the duration of infertility. If the duration of infertility is less, surgical option, if is feasible, should be offered to the patient, whether it is endometriosis, whether it is tubal block. Third thing is cause of tubal block. If it is a tubercular, proven tubercular block, surgery, as I have already highlighted, surgery is having very limited role, and it has to be complementary to ART. In that sense. So cause of tubal block, duration of infertility, and age has to be taken into account before giving the option of surgery. That is for female infertility. For male infertility, again, the option like varicocele, we have already discussed.
No, I am talking of block
Of
passage.
Obstructive azoospermia.
So again, option for reanastomosis like BEA and VBA is there, but unfortunately over the period we have moved on to the ART just because the results have not been very consistent of the surgery. Okay, so that's why if it comes to BBA and BEA, BBA results are still quite okay, but BEA results are not very good. So patient can be advised directly surgical sperm retrieval followed by ICSI in these patients in spite of giving an option of BEA. So first option will be surgical sperm retrieval followed by ICSI. Second option will be surgical and proceed further. Okay.
So I may conclude that it is the overall profile of the patient which is very important, that you first see the overall profile of the patient, which includes I think economical status also, then age also, and then cause of the infertility, what is the basic etiology, why this problem has occurred, and what are her chances. So all these have to be taken into consideration. Then one should decide whether one should go for surgical option or straight away go for the ART or assisted procedures. So I think with that.
Sir, may I add one thing?
Yes,
sir?
madam.
If the patient has tubal ligation, those patients do well with recanalization. That is one of the.
Tubal ligation is a different because that is.
That is what I just wanted to add, sir.
Yes. So, so I thank you all my teachers, faculty, and students, and the institution, Dr. Kalpana Singh and Dr. Archana Kumari, for all their help and coordination and cooperation. Dr. Sanjeeva Reddy, Dr. Harish Doshi, Dr. Kuldeep Jain, Dr. Mala Srivastav, Dr. Padmaja, and I can see Dr. Shobha Goody is also has logged in. So thank you very much, all of you, for this taking part in this fruitful discussion and sparing your valuable time with the students. I can just remind you all once again that all the recording of all these program is on the ICOG website. They are on the website of the Indian College of Obstetrics and Gynecology. You can see the previous year video recording of the program also on these case discussions on the website. And this program is always on the second Sunday of the month from 11:30 to 2 p.m. So I request you to spread the message to all of your friends so that they can take advantage and learn from all these exercises, where we have various faculty from the different parts of the country and student and institute also taking participation from different parts of the country. So we see that we have a very wide participation and we learn from each other so that we put all these things into practice. So thank you very much. If there's nothing more, we can close this session. Dr. Ashish,
for having me here. And it was really wonderful after a long time having a very fruitful discussion.
Yes, Dr. Kuldeep, thank you very much for sparing a valuable. Dr. Ashish is online if you want to say a few words in the end. Otherwise, we close it. Okay, so thank you very much, all of you. Komalji, we can stop recording. Thank you, sir, for giving
us this opportunity.
Okay, sir. Yes, sir.
Host, madam, please stop
Yes,
recording
sir, yes.
so that we can have informal some messages or some inputs.